The JVP waveform. Please like and subscribe. The JVP is identified during physical examination of the internal jugular vein, whilst the CVP is measured with the catheter placed into the internal jugular vein, connected to a column of fluid and a transducer. The normal CVP in a spontaneously breathing supine patient is 0 to 5 mm of mercury. However, it can reach 10 mm of mercury in a mechanically ventilated patient. The CVP is identical to the right atrial pressure in the absence of vena cava obstruction and the right ventricular end diastolic pressure in the absence of tricuspid regurgitation. It is thus equivalent to the right-sided filling pressures. The CVP is affected by a range of factors, most notably volume status, but also venous tone, intrathoracic pressure, left and right ventricular compliance. CVP graph, y-axis in pressure, millimeters mercury, x-axis in time, seconds. To understand the pressure wave, you need to understand two key factors. Right-sided cardiac physiology, and this wave is generated by the transmission of pressure from the right side of the heart. Classically, we always speak about the A wave, the atrial contraction wave, first, as this is the highest pressure generated in health. Therefore, the A wave. The right atria contracts, causing the movement of additional blood, i.e. 40%, from the right atrium into the right ventricle. It's important to note that passive filling of the RV accounts for 60%. This pressure generation is reflected and transmitted up into the neck veins, classically the internal jugular vein, allowing detection. Then, the first X descent. This is caused by reduced RA pressure due to RA relaxation. Then, as the RV fills, the pressure increases and the RV starts to contract against a closed tricuspid valve. As the valve is closed, it bulges into the right atrium and thus forms a second deflection, the C wave. Then, the RV contracts and becomes smaller, allowing the pericardium to have more space and expansion of the right atrium by displacement of the tricuspid valve inferiorly and thus reduce RA pressure. And this leads to the negative deflection X bar. During this period, there's ongoing passive filling of the right atrium, and this will cause an increase in right atrial pressure until this pressure is greater than the right ventricular pressure, causing opening of the tricuspid valve. So this increase in pressure is known as the V wave. The height of the V wave is determined by right atrial compliance and the volume of blood returning back to the heart. Once the tricuspid valve opens, the pressure drops, forming the Y wave. Pathological conditions can affect all parts of the JVP. Classically, A waves can be absent in AF, can be large in pulmonary hypertension and pulmonary stenosis, and significantly large or Canon in complete heart block. The V waves can be large in tricuspid regurgitation.